go. Are we ready? For the next session, I am delighted to introduce a change from the speaker in the original programme. Jonathan Marron from Public Health England, who's Director of Strategy there, is going to talk about some of the public health challenges for CCGs. Thanks.
I was asked today to do a little piece to you on what are the key challenges in public health for CCGs. And I'm going to change the title a little bit because I think the challenge on public health, really, it's not about the challenge for CCGs, it's about the challenge for all of us. How do we, the health service, those of us in the national bodies, local government with their new duty to improve health, industry, voluntary groups, come together to really do something about improving the public's health? So I think the key thing that I'm going to try and get across today is that this is a bigger task, but it's a task that we all have to be part of leading. If we're not there doing it, nobody else is going to. Let's see if this works. Very good. So I think the issue I want to talk about, two things. A little bit, I think there are three big challenges for you. One, talking about health and not illness. Second, how do we start to get a grip on inequalities? And finally, how do we move to a model where we intervene much, much earlier? Sometimes feel it's too much too late sometimes what we do. And then what I'm going to do is talk a little bit about PHE and Public Health England. What can we do? Big new national body, key part of the reforms. How do we help you in your job of driving improvement in health locally? So health. It does seem, and it really felt to me that, a few years ago, and as a director in a PCT, so the commissioning organisation of the past, that we don't really spend a lot of our time talking about health. A lot of time talking about illness, a lot about treating illness, a lot about care for patients. But our real challenge is improving health. How do we ensure that people live full lives, as long as possible, and free of limiting illness? How do we make sure that people can maximise and make the best of the health that's been given to them? And actually, I pulled up the Constitution because it's there. The opening paragraph of the NHS Constitution is improving our health and well-being, supporting us to keep mentally and physically well. So this is our task. I think collectively we've got to think really hard about, okay, what does that mean? And how do we think about how do we spend our money so that we have an impact on health and not just always chase ill health? Public health outcomes framework was government's attempt to say, well, what is health? What are the things that contribute to health? 60 indicators, 54 of which actually exist and a few are placeholders, that tries to map the full range of the things that drive people's health. So from the social determinants, children living in poverty, educational attainment, housing, fuel poverty, homelessness, through to the health improvement things, the things we think about. Do people smoke? What's weight? Alcohol use? Health protection, the things that Public Health England do about making sure that we're protected from environmental threats and from infectious disease. And then finally, the things that probably we're most comfortable with. What is it that the NHS does that helps reduce premature mortality and reduce the burden of disease? But I think the challenge in thinking about health is it's all of this. So our challenge in the NHS is to think about, well, how do we make sure that we're spending our money, £96 billion for NHS England, most of that coming to you. How do we think about that is spent in a way to improve health across the board? How do we work with our partners, and particularly local government with its... I'm just going to pause. Local government. Local government has now been given a legal responsibility to improve the health of its local population. I think that's a tremendous change, probably the most significant thing in the reforms from the recent bill, and the one that absolutely nobody ever talked about. So there's something here about how do we get alongside our colleagues in local authorities, the excitement that's in health and wellbeing boards up and down the country, and start to produce a really joint agenda around improving the health of our people. Not least because some of this is about how do we make sure that we maintain functioning, we intervene early, and we don't see people decline, leading to the enormous cost, and the enormous cost personally and to the NHS of the consequences of some of these things being left. Got a squashy diagram. Health inequalities. One, we all talk about it. The Marmot work, I think, is absolutely laid out the evidence base and the existence of the social gradients in health. This map is from the website we published yesterday. It's called Longer Lives. You'll Google Longer Lives, you'll find it. And what we try to do is just set out in a really easy-to-use manner a whole range of data about premature death and the leading causes by local authority area. any of you who are public health doctors will tell me, well, we've published this for the last 20 years. It's true, but we haven't had a lot of attention. The website went live yesterday. We've had 60,000 people visit it. So something about how do you make something that allows people to talk about performance, inequality, variation. So this is a start, I think, of trying to have a wider conversation with councils. I chose this map simply because it shows you what you all know. The areas which they have the highest levels of socioeconomic challenge are the areas where people die youngest. It's remarkably transparent just from looking at the picture of the map. So that's the headline message. Well, if you drop beneath this, there's also massive variation across individual areas and across areas that have similar levels of deprivation. So, and again, you'll get the sense from the pictures rather than being able to take in the details. We're trying to talk much more in depth about, well, how do areas do against their peers? So this is Solihull in its group of around 13. It's fifth. It's not bad. It's on average for where it fits. Again, for premature death overall, for cancer, for heart disease, lung disease, liver disease, the four big killers. If we were to choose Nottingham against its similar decile of deprivation, well, it doesn't do quite so well. So I think here we've got to start to get into a conversation about, well, what is it that it's not just a social gradient, it's not just deprivation that drives us, it's something about what we do. And I think part of our challenge now across the country is to use that local freedom that we've got to start to say, well, okay, what do we understand about our own local population? What are we doing about those? And are we applying the evidence base of how we might fix it? So I think start of a really interesting story. And again, I'm going to come back to councils. I'd be really interested to see what your local councils start to do with this kind of information, because I doubt it's the way we talk to them about the health problems of their local populations. Now, this one you definitely can't see, but I've included it just because I'm going to point out what it means. This is from a piece of work done across the world called Global Burdens of Disease, published in The Lancet, a UK version in March and the global version last October. And what that did is, the stuff that we've done before, the major causes of death, cancer, CHD, that we all know. This chart is actually by the underlying risk factor. So what is it that leads to people, well, it's years of life loss or premature death. And the chart, which you might see, the top line, nearly 20% of all years of life lost, directly due to smoking. The next line, at 15%, is hypertension. Now, I think we all know that the population modelling suggests that around about a quarter of our population is hypertensive. We also know that on our GP registers, we've got 16% of them on a register and identified. Of those, roughly 80% we probably think are managed well. So if you think about what that means for health, if we could go and find nearly 50% of hypertensives that aren't currently identified, how far can we go in managing those? We know how to manage hypertension. We know the lifestyle changes. Actually, if they don't work, we know the medical interventions that can work for this. How many strokes, how many heart attacks could we stop just from tackling that one issue? And yet it's not what you hear us talk about normally. So something here about how do we start to think about using health resources, the interaction of the health service, to tackle some of these earlier problems and not just pick up the need to handle stroke care properly. We've got to get earlier on in the process of people developing disease. So those are the three things I think I want to leave you as the CCG challenges: thinking about health and making your conversation about health, tackling inequalities, and thinking about how you might intervene earlier and be more preventative. I was going to then spend the next few minutes just what do I think PHE might do for you. So I thought I might start with what PHE is. National agency, an executive agency of the Department of Health, set up from basically all the bits of the old public health system, around about 70 bodies. Last 2 years have been about stitching that together, which I will not share the details and the joys of that process with you. But here's our mission: to protect and improve the nation's health and to address inequalities. And to do that with national and local government, NHS, industry, academia, the public and voluntary sector. There's nothing we can do as a national agency on our own. We'll do this with you, alongside you and with others. This has to be something that it's about how do we change the whole of the system maybe, and maybe even a wider movement to tackle health as opposed to ill health. Okay, I've got one of those clever slides that three things here. What is it? So what is it that we will do as the national agency? And I think it's really around, we'll be a voice. We'll be there agitating nationally for the public's health. And you'll hear us talking about the public's health, not public health. It's not the profession we want to protect. It's about how do we get the best possible outcomes for the public. And how do we do that? Thinking about all of the possibilities. So how do we make sure that we do something about the 26,000 excess winter deaths? The work we've done on warm homes is equally valid as a way of tackling the public's health as some of the work we've done on tackling illness and improving quality of care. So a voice for it, an advocate within government, the source of the evidence. So how can we make sure that we do move to a point that policy, government policy, local policy, NHS executive, and NHS England being the NHSE just dates me, I think it means executive. How do we help the NHS England ensure that its decisions about how it sets priorities, spends resources, the guidance it gives to you, are likely to get the best possible results for the public's health? So real evidence base. And then think, how do we make sure that locally, your Director of Public Health, now a local authority employee, is there for the CCG? How do we make sure that they have access to the best possible, most up-to-date scientific and professional advice that allows you to go to them for the help that you need, ensuring that you're making the best decisions about how you allocate your money and understand the best ways that you might tackle health. The final task on here is about emergency preparedness and making sure that we protect the nation from infectious disease and environmental threats, where we have a much more active role. The consultants in communicable disease control are our staff based locally, and we run that service essentially. So, came into being on the 1st of April. We've published this document, and you find it on our website. It basically says, well, how do we think we can drive improvement? What are the areas that we will focus on? And there are these 5. Reducing preventable deaths, reducing the burden of disease, protecting the country's health from environmental and infectious disease, giving children and young people the best possible start, and improving health in the workplace. Now, we've chosen these as areas where we think that really, with more focus, more effort, we can go further and faster than we have before. Reducing preventable deaths does mean how do we get a real grip on understanding things like hypertension? How do we understand how we intervene on obesity? How do we work with the NHS to ensure that there are effective treatments in place and pathways in place across those issues? Think about the burden of disease. There are lots of things that ail people that don't end up killing us. So how do we tackle mental health? How do we make sure that we get an equal priority for mental health as we think about how we spend our resources alongside the physical ailments? I mean, I think a major challenge is kind of trying to get that in, and again, a joint priority with NHS England, who are very clearly focusing on how to make that parity between physical and mental health come true. Protecting the country's health, I think this is what we know how to do. This is what the Health Protection Agency did, I think, very well. We have an oncoming challenge of antimicrobial resistance. I think we will talk about that more and more. But in here, I think it's really how do we make sure we're doing the things that we've always done that have meant that we don't talk about lots of outbreaks. Although, interestingly, even here, we've managed to make progress over the last few months on measles. And for those of you that are in CCGs or in local GPs and have been taking up the opportunity to try and run the national catch-up campaign, and thank you very much. I think there's a real chance here that we can undo some of the damage that was done with the scare and MMR and make sure that we do get to the point that we have ended the transmission of measles in this country. Giving children and young people the best possible start. If I go back to Sir Michael Marmot's report and the things that he said we needed to do to tackle the social gradient in health. If you ask him what's the one thing we should do, he'll say this. He says you've got to intervene early with children and give them the best possible opportunities, both in health and education. So I guess this starts from neonatal care and antenatal care, and then making sure that through the health visiting programme and others that we really do try and make sure those early years of life give people the best possible opportunities. Final one, workplace health. We put this into, I think, sort of perhaps a slightly different message that we haven't given before, but 17 million of us are in work. How do we use those groups, the employers, to make sure that actually the workplace is somewhere that supports health? We know that work itself is protective for health, and we know that actually the sort of work you have, the amount of control you feel over the work, how empowered you are, also makes a massive difference to your health. So we'll seek to work with employers through the responsibility deal and other projects to try and say, can we really build a much broader, deeper movement for improving health through employment. And indeed, PHE will have to step up to the plate and make sure that we're a model employer in this respect ourselves. I've included this because there's something here around this isn't going to work like we're used to running the NHS. It's not going to work with top-down targets, not going to work with a management chain that many of us, I'm sure, are really familiar with. It's going to work by different organisations, different people coming together to make this happen. So we're being really clear about what we expect of ourselves. These are the behaviours that we expect to display and that you should expect to see us work. That we'll do what we say is important, that we'll work well with other people. We're not trying to undermine people. We speak well of each other. Behaving well when things go wrong, this will be the real test. It's all gone very well so far, so everybody's very happy, but we'll see how we'll carry on the same respectful behaviour when things get difficult. And we'll keep our promises. So as we set out the things we'll do to support health checks, we will make sure we make those happen. We'll make promises and we'll keep them. And speak with candour and courage. It's a really important statement here that many of the public health professionals have worried that moving from either NHS bodies or from the health protection agencies, a separate body, into an executive agency of the Department of Health will limit our ability to speak out and tell the truth. We don't think that's the case. We've got real clarity on our ability to speak to the evidence with our agreements with the department. I think we will see you. I can only ask you to watch us. I think as you watch PHE over the next months and years, we will continue to make sure that we speak openly, clearly and powerfully on the evidence base for improving the public's health. We'll not shy away from those commitments. Last couple of things to say. So while we're a national organisation, we have 15 local centres. So for those of you thinking about how do you access public health advice, I think that the key thing is really build your relationship with the Director of Public Health. He or she is your frontline advisor. Through our 15 centres, we will make sure that we have good and powerful and strong relationships with the local authorities, with the DPH, and that we can make sure that they've got easy access to all of the national expertise that we bring, and indeed the world-class science and evidence that we're assembling in Public Health England. I've got one last one I'm going to show you, because this is a little challenge at the end. So in that little bottom corner, in the bottom left, is the roughly £5 billion we spend on public health labelled spending. Now, I think our challenge is not to say how do we make the most of that £5 billion, although that certainly is a challenge, but how do we make the most of the nearly £100 billion that's spent by local government and the nearly £100 billion that's spent by the NHS to really drive outcomes for the public? How do we make sure that all of our endeavours really are seeing improvements in the overall outcomes and the health status of every one of the people up and down the country? So I think I'll stop there and we'll take questions.
Thank you, Jonathan. We've got 5 or 10 minutes now for questions. If you want to ask a question, if you could wave, and there's a roving mic that will come round. Wave hard because the light means we can't see. One over there and then one over here. Can you introduce yourselves, please, as well?
Hello. All right. My name is Neil Bisbee. My question is, how will you measure success?
Very good. So, Neil, I think that's an excellent question. So the government charged us with making seeing improvements in the outcomes. So the two measures overall they want to see. They want to see life expectancy increase, and they want to see healthy life expectancy increase. Now, I think they're brilliant measures overall, but they will move very slowly. So I think our challenge now is to say, well, okay, how do we come together and choose 3 or 4 things, 3 or 4 fundamentally important things that will allow us to say that we've made a significant change and a significant improvement in the public's health. Now, the document I showed you earlier identifies some of the areas we think we might work in. What we're now doing is trying to talk to people about saying, well, what would be the equivalent? And I'm going to choose my language carefully here because I don't think we're going into the world of targets. But if you think about the way the A&E galvanised the NHS to do something that both the public understood was better for them, they've got access, but it also meant we had to really think about how you ran hospitals, how you ran the system. What are the things that we could set as goals or ambitions that you could join in with, that local authorities could join in with, that would allow us to really build momentum for change. So things that we think about, could we really commit to eliminating the transmission of measles? I mean, that feels like a tangible, achievable thing that would be worth doing. What commitment could we make on smoking? We know it's the number one public health issue. We know it's the leading cause of early death. What collectively could we care for there? Dementia. Could we make a commitment to delay the onset of dementia? So I think the thing that we're really interested in over the next 3 or 4 months is talking to people and thinking about what are the small number of things that would see a step change in improvement, and then we'll go after them, and we'll spend the next 3 or 4 years using everything that we've got, working with everybody else to make sure we run those down. I think that kind of focus is what we need next. You know, we've spent a lot of time understanding the scope of the challenge. I think we need to choose some things that we'll do to actually drive change.
Thank you. Somebody over here, do you want to wave? And then you next over there.
You could just pass that down to the
That one down there.
Thank you. My name's Mona Sood. I'm a pharmacist and ex-NHS. I wanted to say thank you for the presentation to start with, but also I wanted to pick up on a key point, and that was around intervening early. Now, having worked in PCTs for many, many years, thinking about long-term conditions, the common theme with the long-term conditions, there are no short-term quick wins. Yet NHS budgets are annual. So to actually see a change and an improvement in the health of the nation, we're going to have to look at long-term investment strategies. And if I take diabetes as an example, which is thought to become the world's 5th largest cause of death by 2040, how can we encourage financially challenged CCGs to invest in long-term strategies for managing chronic diseases?
So again, another super challenge. So there's a couple things here, aren't there? So one, I think we've got to make sure that people believe it will work. That, you know, when I sat in the PCT, I think one of the real challenges to think about this is people weren't quite sure. So to make an investment that you're going to see, it might take 4 or 5 years to pay off. Without being sure you're doing the right thing, it's very hard to make that step. So I think there's something about how do we just be much clearer about what are the things that work, what the return on investment is, and why the case can be made. So I think that's part of it. I think the other part is we've just got to be a bit bolder and a bit more confident. Now, it is true that we get our money every year, but I'll tell you what, I'll have a pretty good guess at what your money will be for the next 5 years, because I don't think it's going to grow by very much, and I don't think it's going to go down. So I think what we've really got to challenge ourselves now is not, is it 3% or 4% or 5% growth each year, but what do we do with the 96 billion we've already got? So I think there's a challenge here for the commissioning community to think about how do we find the space to try and do some of these things. Now, I know NHS England are thinking hard about this question and really want to try and start a conversation shortly. I mean, David Nick mentioned some of these things last week at the Confed around how do we have a much more stable long-term view to challenging some of these things. That the agenda we face ain't going to be fixed in an 18-month period. We've got to start now to think about what must we start investing in that will allow us to have an NHS not in 1 year's time, but in 10 or 20 years' time that's effective, affordable, and people are still proud of, to be quite frank.
Thank you. Somebody over here in the middle was... Yeah. No, in the middle of the aisle, and then down here next. That's it.
Hi, Jonathan. Simon Setti, Deputy Director of Commissioning at Gloucestershire CCG. The lady over there rather asked a similar question, but looking at the presentations today and the conversations in our CCG, the prime imperative at the moment is how do we save money and deliver care in the next kind of shorter period. And I think there's one question which is about how do we make sure we focus on the long term. Yeah. But is there any way we can increase the efficacy and the centrality of public health conversations in those next short-term delivery of savings and improved quality?
Yeah, I think so. I think yes, and there is a thing here, isn't it? We tend to talk about long-term and public health. Some of these things pay off very quickly. You know, if we manage to get control of high blood pressure, that pays quickly. Smoking, actually getting people to quit smoking, you start to see impacts on heart disease in 2 or 3 years. So these things are not. It's not jam 20 years tomorrow. I think we have a challenge to help you come up with what are the 10 top interventions that pay back on a rapid time scale, that people can start to use. Maybe if it's motivated by financially, they think, right, we have a financial problem, this will help you. I think we've got to help get people to do the right thing to solve their financial problems, as opposed to some of the approaches we've taken in the past to try and just muddle through. So I think there's a challenge to us about how do we get you the evidence of what works quickly, and let's start there. And hey, the longer term things will come, because if the things we say work in short order work and people take them up, you'll believe us when we ask you to do something more difficult. So I think you've hit our core challenge on the head with that question. So watch our space.
Okay, there's somebody down at the front, yeah.
Eileen Tipper, lay member of a commissioning group. It's about your priorities about health in the workplace. Unless I've misunderstood the media reports, the regulatory framework about making the workplace a safer place is being driven back, and the funding of the Health and Safety Executive is being reduced. I can see the use of the workplace as an education, the source of health education. What specifically are you going to do to compensate for this diminution of the regulatory framework?
So I think with the health in the workplace, I think where we like to is not into the regulation of workplace accidents, safety, which is the Health and Safety Executive's world, but what is it that we can do with employers to help them understand how they keep a healthy workforce? What is it in the way you design jobs? What is it in the way you services you provide? What is it in how you encourage people to take healthier choices? The one is really good for the public's health, but actually it's really good for your employees' health and gets your employees to work more productively. So I think it's that agenda of healthy people driving healthy firms and, dare I say, a healthy economy that is the agenda we like to pick up. And I think the health and safety issues are probably not the place we'll start from. But it might be interesting how those two things come together as we start to talk about this in some detail.
Okay, thank you. I think it's that lady over here on the end.
Hi there, my name's Jude Williams, and I was Deputy Head of the Health and Equalities National Support Team, but that ended in March 2011. And I think it was a question to you, because we battled away, we visited all the spearheads, we supported them, we were shown to be effective in that methodology. And we developed a whole load of resources, which are sort of archived somewhere so deep in DH recesses, I've now forgotten how to get them. Would it be worth getting those out, giving them a dust down and a freshen up, because we worked really hard on them and they were based on our practice, which we did for over 2 years.
Yeah, so the short answer, of course, is yes. Chris Bentley is the man I'm using to try and recapture some of that knowledge. We had him with us in the transition team for a little while, and that was really helpful. And look, hey, the reality of all this stuff is, somewhere across the NHS we've invented this before, and we love inventing it again, don't we? So I think we just like to cut that reinvention thing out and just copy all the good stuff, and then say, okay, collectively, what is it that we know works, and can we just make sure that everybody's done it? There's something here about, there's a whole set of things that if we all reach the practice of the best, we'd be miles on from where we are today. So let's get that done, and then we'll worry about what the next steps are and the next set of good practice. So I think one of my colleagues talks about industrialisation of this stuff, which I'm not sure is the right word for the health service, but you kind of get what it means. Can we do this at scale and reach, rather than every one of us inventing the next stage each time? So the more we can resurrect, the better, I think.
I'm going to ask a question now, and then we might have time for one more over there. I'm from Blackpool CCG, where we have the worst life expectancy in the country and have had for many years. And we, in fact, did do a lot of work with the Health Inequalities National Support Team, very productive work. And we are still using the resources and the information from that. One of the problems we've got, and we are really doing everything we can think of and everything the experts tell us to do, but the real wins are going to come from things like the tobacco legislation, from alcohol pricing, from plain packaging of tobacco, from the big stuff that's got to be done nationally. How much influence do you think you are having nationally on getting those messages across? And are we going to see any action, particularly around legislation for some of those things?
Yeah, so the government's consulted on both those things, and as you know, there's no decision yet. So the Secretary of State is still looking at the evidence and coming to a view of whether the government wishes to proceed. So what's our role? I think we've been clear in supporting both of them. We're clear in making sure that the evidence is available, and we'll continue to promote that. I think more broadly, the question is we have to, what are all the other things that everybody else can do? So let's not wait for the government to make a decision, but let's try and do what are the things that Blackpool Council can do in tackling tobacco control. Perhaps you might want to think about the sale of cigarettes to underage children, the enforcement. I know you've done great work on hypertension. How can we promote that? So I think the challenge over the next period is to try and be really clear about what each of us can do at each level of the organisation. And if we're all doing our bit, I think it becomes much more powerful than to say, look, the only thing that's left is... it gets a bit stale if the conversation is only about the government doing something, and I think we've got to help build momentum more broadly for the changes that we think we can introduce to improve the public's health, and that's got to be the challenge for facing us.
Okay. One more just here, and Jonathan has to answer it in 20 seconds. No pressure or anything.
I'm Dr. Al-Kamil, locum doctor. Just 2 points. The first one is the mental health patients with their physical needs and all the checkup, and who will be responsible about commissioning it, whether the GP or the psychiatrist. And the next question is the alcoholics related problems and services, how it will be affected by the new commissioning in London area.
Yeah. Okay. So on alcohol services, so alcohol services go to local authorities. So a big challenge and a big change in the way you might do that. I think the local government opportunity is a really interesting one to say, how do we bed responsibility for these health issues in amongst the responsibilities for the, if you like, the health of the community more broadly. I think we've heard nothing but positive things from local authorities about how they want to take on that task, and there's no evidence so far of anything dropping aside. So I think I'd say I'm really positive about that, how that might turn out. On mental health, I think the real challenge is how do we join it all up, and I think locally you'll have to find ways to make sure that the local services integrate, that the psychiatrist, the GP, and indeed the local authority services start to wrap around the patient in a much more effective manner.
Thanks very much. I'm afraid we've run out of time. Can we just thank Jonathan very much? It's been a very interesting discussion.
Thank you.